Welcome to Podium Perspectives, powered by Vanium Group.
Welcome to the first episode of Podium Perspectives, Advances in the Treatment of Multiple Myeloma ASH Highlights, a new podcast that shares up-to-date insights across oncology and rare diseases. I'm Dr. Sagar Lonial. I'm excited to start this series with my colleague, Dr. Ajai Chari.
In today's episode, Vanium Group has brought us together to discuss updates from ASH 2025 on multiple myeloma.
Okay, so let's get started with bispecifics. I think everybody was really intrigued by the MajesTEC-3 data. Really long progression-free survival. Tell me what you think.
Yeah, I think it was basically Dara-Tech versus DPD-DVD, and I think the efficacy really is unparalleled. The hazard ratio is 0.17 for PFS, which also translated into an OS hazard ratio of 0.46. And I think everybody was posting on social media about these plateaus, and I think it's really remarkable. And it's the first, I think why this is important, it's the first phase 3 randomized study we have of a bispecific. Up till now, everything's been single arm. And I think the data looks fantastic. I'd love to hear your thoughts. I think the challenge, one issue is that because you could not be CD38 refractory and there were only 5% exposed, how do we use this regimen because of increasing frontline CD38 use? But thoughts?
Yeah, I mean, I think I think the data looked outstanding. It's hard to argue with a hazard ratio of 0.17. There are some caveats to this in the sense that you really need to be on your toes with infection prevention. And so I think for a practice that's not used to giving BCMA bispecifics, there's a little bit of a learning curve there, but it's not insurmountable, and clearly it results in long-term efficacy. What I think we as a community and all of our colleagues in general oncology need to think about is how long do you give this? The discussion around plateau is a little hard because the follow-up was at 36 months, which is right where that plateau sort of is. What's it going to look like? But do we need to keep giving people this therapy? I think that was one of the two big discussions, I think, at the meeting in general for myeloma.
Yeah, and to that point, I think the two additional kind of relevant data sets were the French data presented by Solomon Manier, who did the same tech DARA, but now it was the newly diagnosed patients. These were transplant ineligible with a median age of 73. And what I thought about that data set, in some ways more impactful, but even more highlighting your point about infection mitigation strategies, because in MajesTEC-3, there was a crossover in overall survival, right? Like it takes, and for an off-the-shelf product, you should be getting benefits right away. And I think the deaths that are seen in that first 9 months, what's nice to see about the French data was there was no deaths, and the rates of grade 3-4 infection was only about 15%, but they were very aggressive with IVIG, PJP prophylaxis, infection mitigation strategies. And of course, it's a smaller contained group of investigators, right? It's a French group as opposed to a global study. And I think it just speaks to this importance of community doctors knowing what they're doing with this regimen. And I think the other data that was presented by the Penn group in a poster was, to your point about do we need indefinite therapy, showing really 19-month PFS with 6 months of duration of therapy, even in more advanced treatment with BCMA bispecific. I think we need larger data sets, confirmatory, making sure that, high-risk subgroups are well represented. But to your point, these bispecifics are so profoundly effective. How much do you really need, particularly as you move the product up earlier? So really cool data.
Yeah. So, I think what MajesTEC-3 and the Lille study really suggested was that combinations are where we're going. And I think you and I have been big proponents of combinations in every drug class that we have. So I think the big question to me is, what is the better partner for a bispecific? Is it a CD38 antibody, as we saw in MajesTEC-3, or is it a CELMoD, as we saw in MagnetisM-30, with ELRA in combination with iberdomide showing 98% response rate, substantial proportion of patients achieved MRD negativity, also with less frequent dosing of the ELRA in order to partner with the CELMoD. I really think this is an interesting and intriguing way to maintain T-cell health and at the same time get synergy.
Totally agree. There was also Monumental 2, which was the same TAL plus POM and in PFS of almost 26 months. I think clearly the the CELMoDs and IMiDs can augment bispecifics like they do T cell activation. I think the key question, again, for community doctor, if you're going to reach for these agents in combination, is please pay attention to the doses and details, right? Don't start during step-up, start cycle 2. For example, pomalidomide, we don't use 4 or 3, we use 2 milligrams. And despite that, we see a fair number of interruptions, dose reduction. So I think it's a great combination that you can do readily because it's a parenteral and oral drug, but I think just buyer beware of the dosing and schedule because that's really important for delivering these safely.
Yeah, and it's interesting that you mentioned that ability to do that now. For a large number of our talc patients, we're already starting with POM as a partner, and because we've noticed that there are patients who may progress on single agent talc, and you add POM and you recapture that response. So if you're going to recapture, why not do it earlier and perhaps again spread the doses out and get to less frequent dosing in general? So really interesting synergy there. So the last of our bispecifics we'll talk about is actually the trispecific. So why use 2 when you can use one that is 2, right? GPRC, 5D, and BCMA in the same partnership. Really intriguing idea. And to me, the GPRC related adverse events are significantly lower.
Yeah, and I think it's rare to see 100% response rate, but that's really what this showed in relatively heavily treated population, although they were naive to both BCMA and GPRC targeting therapy. But the 100% response rate, almost 80% CR, really impressive. And I think particularly why I think community may be interested. There's only one step-up dose, low rates of CRS, and it's monthly dosing. And maybe that's part of the efficacy here to our earlier theme of like maybe less is more. We know even with TAL, for example, every 2-week dosing gives you much better PFS than weekly dosing. And is that because we've seen with translational data, you get less T cell exhaustion. So I think the field's moving to kind of more convenient outpatient, and hopefully the true impact of T cell engagers really will come from community use, not academia, right? And I think these are these frailer patients, older patients who can't trek all the way. And to see these kinds of results for an off-the-shelf product, I think is outstanding. And we should mention there was another GPRC BCMA trispecific coming from China, from Innovent, which was also showing exciting data, and even combining these targets via CAR T. So I think the field's moving towards combination therapy within immunotherapy itself. So nice to see these early data sets.
Yeah, no, I think very exciting. And again, the question is, how do you partner them? What do you combine them with? And can we talk about limited duration therapy? So let's switch to CARs. So we had probably 4 abstracts in CARs to cover. Let's do the one with the longest follow-up, CARTITUDE-4, long-term follow-up, presented by a number of investigators that suggests that if you're standard risk and you got cilta-cel in 1 to 3 prior lines, your outcomes were just outstanding. I don't know about your center, but we have traditionally reserved early CAR for the high risk, the functional high risk. This really asks the question, should they be treated earlier, the standard risk even?
Yeah, I think it's one of those things that we wrestle with at the bedside, which is like population statistics versus individual decision making, right? Like at a population level, you're getting better PFS, better OS, but at the individual level, there are these rare one-off, maybe probably 1% for delayed neurotox, 1% colitis, 1% SPM. And so if you're in those 1% buckets, it sucks, right? But statistically, it's unlikely. And I think the only other thing I didn't like about the analysis was they excluded people like at 1 year, if you were alive and well at 1 year. And that's the Russian roulette here, is like, how do you know you're in that group? And if you died in that early cohort. So I still think it's a great product. It's the single best and treatment-free interval, quality of life. But I wrestle with, with this 1 to 2 line of therapy. Clearly the more high risk, EMD, genomic, I'll use it as soon as I can get it. But for those standard risk, I think it's really a shared decision making. And I wonder how you're going to approach this.
No, I think it's the same. And the anecdote I say is I saw a patient last week who had a 10-year first remission, and we said CAR, we said bispecific, or we said triplet, DPD, something along those lines. And, for her, she chose DPD as the triplet because she just didn't want even the risks of infections with one or potential toxicity with the other. And so you're right, it is going to end up being a conversation we have with people about what to do. Although TechDara makes it a little bit more complicated, I think. Yeah. So
Absolutely.
imagine one, is anito-cel same, better? What do you think? Really interesting data.
Well, I think we have to remember that we're so early. These are like the ide-cel, cilta-cel are like first generation products, and we're learning so much as we go. And these newer products are benefiting from that cultural knowledge of debulking strategies and bridging so that we're getting less inflammatory milieu. So I think part of it is that, but part of it is also probably product, right? We're not so far seeing these one-off delayed neurotox and colitis, although keeping in mind that if it's a rare toxicity, you really need larger numbers, longer follow-up to do that. But I think the data are quite exciting. The efficacy looks good. I just think we need a little bit longer follow-up. It's about 117 patients. It's about a year and a half follow-up. And this is where you start to see with cilta-cel that plateau. So we'll need to see whether plateau matches. And it's going to be like this efficacy safety trade-off. Is there any efficacy trade-off or not? I think that's the key question. What do you think?
Yeah, no, I think you're absolutely right. I think it's too soon to say as good or maybe close to as good or not as good. But I do worry about adverse events in the sense that we didn't really see all we saw with cilta-cel until we started treating a lot more patients. So I'm going to hold judgment on that until we get a bigger cohort to fully appreciate what the risk of adverse events is really going to look like. But I do think, between the in vivo CAR, which is just the neatest idea, right? You don't even have to do ex vivo expansion. You don't have to do LD chemo. None of that. They saw great responses. Obviously, very, very short follow-up. N is really tiny. But to me, that actually solves a whole lot of problems. And then FASCAR, the dual targeting FASCAR, that I think also looks really interesting and exciting. I mean, I think we don't have a lot of data on either of them, but I think they certainly are future-looking approaches, right?
Totally. I think the one benefit of the CAR over bispecifics is the treatment-free interval, but then the downside is the hassle, the logistics, the selection, the apheresis. And if you can get past that, you're kind of getting an off-the-shelf product, but with one and done type of duration. And I think so that's why the in vivo CAR got such a big splash, although for patients. I think the dual CARs, which are also fast CAR, can theoretically have a manufacturing period of a couple of days, which again is another limitation of CAR T. But looking great so far, 100% response rate in the newly diagnosed population. Yet another CAR. Both of these have not shown those delayed neurotox or colitis yet, but again, very small numbers, very early follow-up. But super exciting to have these next generation cars that are just showing how much we have to learn and how bright the future is.
Yeah, really exciting, really exciting. So let's get back to some stuff that folks can do in their offices today. So one abstract came to us from Europe, and that's the COBRA abstract, which in my view is less bortezomib is not as good as more carfilzomib. I don't want to relitigate K versus V, but I don't think this helped us answer that question.
Yeah, I think many people are questioning. There's no question their side effect profiles are different, neuropathy versus cardiac hypertension, but the efficacy, allegedly this was intended to compare, but like you said, 6 months of bortezomib versus 12 months of carfilzomib. I don't know that this changes the needle. And the good thing in the US is even if you start with V, you can switch to K, right? You're not locked into it. So if you don't like the response, you're getting side effects, it's not like you must do this forever. And I like that flexibility that we have in the US.
Yeah, absolutely. Absolutely. So Ariga, if you hadn't had Dara in the maintenance setting is better with Len than Len alone. I don't think it's a huge surprise, right? Because you're trying to make up some of that benefit you got from a quad as initial induction therapy. Do you extrapolate this data to what you do in your everyday practice?
I think what was interesting about this presentation was the Sankey plot, which just shows that like when you start with DR versus R, which was the study in patients who importantly did not have frontline CD38. But if you were MRD positive and you compare those groups, what you see over time is that there's less MRD negatives and going to progression. And then you also see deepening, which is not surprising because we already have a PFS readout. So I think it matches that. I think the challenge with this study, of course, is with so much frontline CD38 exposure, how do you interpret this data? But it does, I think, support that you can deepen responses over time. And it's not just all of what happens after transplant. What are your thoughts?
Yeah, I mean, for people that don't get CD38 up front, then this is a no-brainer. I think you apply it. For people that did, I'm still waiting on a little bit more data before I routinely incorporate Daralen as maintenance. I'll do it for people that don't achieve a VGPR in the post-transplant setting, but I'm still holding out for that randomized German study to tell me what the benefit is getting it both upfront and in the maintenance setting.
I think to your point, to me, I totally agree. I use it in high-risk patients and people who are not MRD negative after transplant, but I'm not sure why if everybody needs 2 drugs if they're MRD negative standard risk, because the curves look pretty comparable so far in multiple data sets. So yeah, I agree totally with your interpretation.
All right, so let's wrap up with Bella. And the reason I saved this is because it just got reapproved recently. We saw updates on Dream 7 and Dream 8. I actually presented some data on ocular toxicity. Tell me sort of your thoughts on those data and how it fits in.
I mean, we now know in multiple data sets, BCMA is a better antigen than CD38, whether you're doing it with bispecific or with CAR or with an ADC. There's a room for Bella, no step up, outpatient dosing, no CRS, relatively infrequent dosing long term, not mandating IVIG. Those are all plus points for Bella. I think the challenge is going to be just trying to get that dosing schedule correct, which the clinical trials did one thing and we're all doing separate things, but how they're going to navigate that label is the tricky part. How are you looking at Bella data?
No, I mean, from my perspective, dosing every 8 to 12 weeks, which is what we do in our BPD maintenance for high risk. And I think to speak to your point, I'm not sure DARA offers that much in high risk maintenance. So I'm looking for something else. Was really quite easy. If patients have some visual changes, it's fairly transient, and I think it's reversible relatively quickly. So I'm excited to have it back in my pocket. So, yeah.
Great. Well, thank you all for listening to this first episode of Podium Perspectives.
Thanks for joining Podium Perspectives, powered by Vanium Group. This episode is for educational purposes only and is not medical advice.